I am Dr. Zarin Kidwai. Sorry about this delay. When we were planning the lecture, I suppose we did not. So anyway, I hope people are now ready to get started. Anyway, I am Zarin Kidwai. I'm an internal medicine physician. And on behalf of AMWPA, I would like to welcome you to our online lecture series. Before I begin, I'm going to start first with a short surah in remembrance of Allah Almighty. I will be reading Surah Al-Ikhlas. Qul Wallahu Ahad, Allahu Samad, Lam Yalid, Walam Yulad. In the name of Allah, most merciful, most gracious. Say, He is Allah, the one and only. Allah, the eternal absolute. He begetteth not, nor is he begotten, and there is none like unto him. So today's lecture is going to be on a very popular topic. We commonly call it GERD, or gastroesophageal reflux disease, or heartburn. And just before we start, I just want to give you an introduction about what AMWPA is. AMWPA stands for American Muslim Women Physicians Association. We are a nonprofit organization of obviously Muslim women physicians and allied health. Just a reminder, please mute yourself. If you have something to say, you can say it in chat. If you have any questions, you can send them in chat, and I will give you further instructions in just a second. So anyway, AMWPA is a nonprofit organization, and we provide health prevention programs across DFW area. We also promote health education, not just in the community, but as well as budding healthcare providers, medical students, nursing students, etc. In 2020 and 2021, obviously we had restrictions on how much we could do as far as preventive health, but we were able to, alhamdulillah, work towards educating people through our online classes. We were able to provide 30,000 or more masks in the community to the needy, disposable and reusable masks. We were also able to provide almost 500 free flu vaccination. We had our first drive-through vaccine drive. We provided 1,100 meals to ER physicians and medical staff when the COVID pandemic started, to thank those at the front who were taking care of COVID patients. So without further ado, I will introduce today's speaker. She is Dr. Tasneem Ahmed. Dr. Ahmed is an alumna of UT Austin. She obtained her MD degree from UNT Health Science Center, residency at Cleveland Clinic. She also did her fellowship there. She specializes in gastroenterology, and she has special interest in inflammatory bowel disease. Dr. Ahmed served on the faculty of UT Southwestern for 10 years and is now in practice. She is a staff at Harris Methodist Hospital in Fort Worth. So Dr. Tasneem Ahmed, over to you.
Jazakallah, Dr. Kidwai. Assalamu alaikum, everybody.
Before I hand over to Dr. Tasneem Ahmed, I'm sure you have lots of questions. We will provide plenty of time to discuss all your questions. Send them in the chat box. We will track them, Dr. Tasneem and I, and we will address all your questions.
Okay, Jazakallah. Assalamu alaikum, everybody. I will start my talk both on gastroesophageal reflux disease, and I thought I would also touch base on colon cancer screening. Okay, Bismillahir Rahmanir Rahim. So what is reflux? What are the causes? What is the treatment? How do we prevent it? And when do we see the doctor when we have reflux symptoms? This is a brief overview of what we will be reviewing over the next hour. Okay, so what is heartburn? Heartburn, reflux, indigestion, they're sort of all within this umbrella category of gastroesophageal reflux disease, otherwise known as GERD. And basically the most common symptom that people have is a burning sensation that starts low in the chest and rises up. And essentially it's sort of that burning chest pain. Other symptoms people have are reflux, acid reflux, where they can actually feel acid coming up in the back of their throat. They have a sour taste in the back of their mouth. They have regurgitation, meaning that sensation of food or liquids coming back up, or the sensation of just burning in the upper abdomen. These are all symptoms of gastroesophageal reflux disease. And at the bottom right, I just have a picture of what this can do to your esophagus. Your esophagus is your food pipe. So as soon as you swallow, food goes down into your esophagus. And the main role for the esophagus in your digestive tract is essentially to move food from your mouth into your stomach. And you can see these white areas, these red areas here. These are all areas where there is acid refluxing up into the esophagus and causing ulcers, inflammation, redness, and swelling. And so this, when you can have this with severe reflux, and you can have severe heartburn and not have any changes in your esophagus. So there are typical symptoms that I just reviewed, and then there are atypical symptoms, and they can occur both inside and outside the GI tract. And the atypical symptoms are people who have recurrent throat clearing, who are, you hear them on an airplane or in meetings clearing their throat. If you have a dry cough, if you have chest pain, not necessarily burning chest pain, but just discomfort of the chest after meals, that may signify reflux. Hoarseness, so just voice changes, a sore throat. Oftentimes we get consultations from dentists when dentists notice tooth decay at patients' annual dental exam. The dentist will often see evidence of acid injury to the enamel of the teeth. And then sleep disturbances, where patients will be fine during the day, and then right before they go to bed, or they'll have, severe heartburn or acid taste in the back of their throat right when they're about to go to bed, or more severely, it wakes them up from their sleep where they actually have regurgitation, meaning acid actually coming in the back of their throat, waking them up from sleep, or they wake up coughing or choking, or wake up with heartburn. And definitely that requires therapy. So how common is this? I feel like almost everyone will experience heartburn pain at some point in their lives. It affects 20 to 30 million Americans. And in women, oftentimes the very first time they experience heartburn is during pregnancy. More than 40% of people suffer from heartburn pain at least one time per month. And 95% of people link their symptoms to a particular food, meaning that they notice, they notice that, certain foods like spaghetti sauce or fried chicken or biryani or like a spicy curry, that will certainly trigger their heartburn. And so which is important because, what you put into your gut affects how your gut reacts to it. And so oftentimes people have heartburn only if they ingest a particular food. Most of the time symptoms occur during the day, but there is a good majority of people that also experience symptoms at night. And as I mentioned, more than 50% of all pregnant women will have some degree of heartburn and reflux, and more commonly in the third trimester. And it's because you have this growth in the uterus where the baby is growing and it's pressing against the diaphragm and pressing up into the esophagus, which just mechanically will increase your reflux into your esophagus. So what causes reflux and GERD? So here is a nice pictorial. This is your healthy stomach right here. Right here's your esophagus. You see these two indentations. This is your diaphragmatic crus, and there's your stomach. And your stomach lives below your diaphragm, below in your abdominal cavity. Your esophagus is in your chest cavity. And you see the sphincter, which is a tight valve that is usually contracted, meaning it stays closed to prevent the stomach contents from coming into the esophagus. And the purpose of the stomach is really just to churn and mix food to get it ready to enter into the small intestine where absorption starts. Your healthy stomach on your left, in the middle here is a GERD stomach, where now you see that lower esophageal sphincter, that valve between your esophagus and your stomach, is looser. And you can see that stomach juices, namely acid, because you need acid to digest food, to break down food, to break down proteins and carbohydrates and fats and all the things that we eat. The stomach juices then pass up into the esophagus. And with this acid reflux, the sphincter doesn't close very well. And so this is a mechanical issue where acid and stomach juices are coming up into the esophagus, then causing heartburn, acid reflux, sour taste in the back of your throat, choking, coughing, chest discomfort. So what predisposes people to reflux? So a malfunctioning lower esophageal sphincter, obesity. So the heavier you are, the more pressure the bigger your stomach is, and the more pressure mechanically it's putting up on your esophagus, and it predisposes to reflux. Smoking. So smoking will loosen your lower esophageal sphincter, and when it's loose, stomach acid and stomach contents can move up. Fried fatty foods like a cheeseburger, fries, those sort of things can predispose to reflux. And certain medications. So certain medications like ibuprofen type medicines, non-steroidal anti-inflammatories, steroids, sometimes those big antibiotic pills that people have to take can certainly predispose to reflux. Sorry. Okay, so diet. So what foods trigger acid reflux? And we're talking about foods that relax the lower esophageal sphincter. Remember, we want the lower esophageal sphincter to be closed. The foods that trigger acid reflux, so alcohol, smoking, black pepper, garlic, chocolate, citrus fruits, caffeine, peppermint, tomato-based foods. These are all things that predispose to acid reflux and can trigger foods. And when patients come in and tell us about these symptoms, oftentimes we give them this list of foods to cut back by about at least 50%, if not avoid in certain cases. The top triggers, again, as I mentioned, are fatty foods, large portions. So think about it. The larger your portion is, the more stomach contents there are, the more acid your stomach has to produce, hence the higher risk of developing reflux. Late night meals. So we usually tell people to time your last meal at least 3 hours before you go to bed. And that basically gives your stomach enough time to churn all that food and empty it into the small intestine. And contrary to what our parents may have told us, or our grandparents, we do want to go to bed with an empty stomach. A full stomach or even a half full stomach, just predisposes us to having reflux. Smoking loosens your lower esophageal sphincter, and not to mention smoking causes cancer and a number of deleterious effects on your whole body. So smoking is something we tell people to absolutely stop. Pregnancy, like we talked about, that uterus, the large uterus that's carrying the baby, presses up against the stomach, which presses against the diaphragm and loosens the lower esophageal sphincter and predisposes to acid reflux. And obesity as well. It's the same concept. The larger you are, the heavier you are, the more tension you're putting on your diaphragm and mechanically putting pressure on your esophagus and predisposing to a reflux. So, how do we treat reflux? And the treatment really centers upon lifestyle changes. And being a gastroenterologist, I sort of have an easy first step in all my plans is to change your diet, and really in terms of GI disorders, for the most part, eating cleaner, healthier, balanced diets really does a lot of good on your GI tract and will help improve many, many symptoms from GI disorders. So specific to GERD, we recommend first eat smaller and more frequent meals. And, rather than eating 3 large meals throughout the day, I think eating smaller volume meals and perhaps eating more frequently or doing small snacks is more beneficial to reflux. Avoiding eating right before bedtime, like I mentioned, it's best to minimize the time to minimize eating late, meaning you definitely want to stop eating at least 3 hours before your bedtime. Minimize aspirin and NSAIDs. These are the medications we talked about that predispose to reflux. We recommend to minimize caffeine. In terms of, when patients come to me, I ask them, how much caffeine do you drink? And I list everything, how many cups of coffee, how many tea, sweet tea, in Texas, sweet tea is very, very common, how much sodas, how much juice. I really try to get a sense of people's liquid intake because caffeine can certainly increase your risk of reflux. We definitely recommend to stop smoking. And we recommend to elevate the head of the bed to allow gravity to keep acid in the stomach and avoid reflux. And so gravity is our best friend. So elevating the head of the bed will really help, just obviously not allow acid to come back up into the esophagus and stay in the stomach. So these are our first line of medications that we recommend for gastroesophageal reflux disease. And the first is antacids, and these are the ones that you see over the counter. These bind excess acid in the stomach and they coat the esophagus. So this isn't necessarily blocking acid production. It's just whatever excess acid it is, it helps to bind it and just sort of act as like a topical barrier, so to speak, to your esophagus and your stomach. And these are really recommended for people who have, heartburn, reflux, like once a week, if that. So very uncommon, and more so if they're going to go out to a restaurant or they're out traveling and they know that they're going to be eating poorly, then, I'll definitely recommend patients to take some Maalox with them, some Rolaids, some Tums, and they can take it as needed. But if you are taking these antacids, more than 3 times a week, then I certainly would recommend to see a gastroenterologist, or actually first your primary care doctor, who can certainly manage reflux. The next line is your H2 blockers, your antihistamines, and these block the action of histamine on acid-producing cells of the stomach. And the most common is Pepcid. People used to use Zantac a lot. I mean, I've used Zantac myself, but it was taken off the market now, I think 2 years ago, because there was a carcinogen found as one of the ingredients in Zantac. So it's taken off the market. If you have any Zantac left at home, another name for it is ranitidine, then I would certainly recommend to just throw it out. So Pepcid and Tagamet are the most common antihistamines, and these are all available over the counter. These are not something that you need a prescription for. Your physician can certainly write a prescription for this, but you don't need one. And Pepcid is probably my first go-to antihistamine that I tell people to take if they have reflux at least 3 times a week, and very effective for people who have nocturnal reflux. So if they notice that they're having symptoms right before they go to bed, or symptoms that wake them up in the middle of the night, then Pepcid is one of the most effective medicines. The next class is the proton pump inhibitors, and these are the most effective class of medication that blocks acid in the stomach. And you'll see multiple different treatment options. And I'll go by their brand names because that's what's written on the prescription bottles, and that's what you'll see. There's Dexilant, Nexium, Prevacid, Prilosec, Zegerid, Protonix, and Acifex. And so these are all proton pump inhibitors. They block the pumps, the acid pumps in the stomach. They are the most effective class of medications for reflux disease. These are indicated if your physician does an upper endoscopy and finds esophagitis, ulcers in the esophagus. If you have an ulcer in your stomach, then you are prescribed this medicine. These are medicines that are overall quite safe to take, but do require some degree of monitoring. And people have sort of their preference in terms of what they feel respond to more. Some people swear by Nexium, some people swear by Protonix, some people swear by Prilosec. Looking at data, overall, they're all equally effective. Like most things in medicine, I think what you end up getting is what is on your insurance plan. But for the most part, they are equally effective. So prevention is key. I think that is, one of the staples of AMWPA's tenets is, prevention. And with reflux disease, really, it's important to have a healthy diet, healthy eating habits. You don't want to have, large meals, fried fatty food. You don't want to be heavy in carbs and heavy in fats. You really want to have a balanced diet of fruits and vegetables. You want to make sure that you drink plenty of water. You want to be very cognizant of what your liquid intake entails, how much water you're drinking, how much dairy you're drinking, how much sodas and caffeinated beverages. Portion control is incredibly important. Minimizing acidic foods is important. Again, I think I've mentioned several times that we should stop eating 3 hours before bedtime and practicing moderation. And like I mentioned already, I don't ever really tell my patients to stop anything unless it's smoking. But I always, my first visit when I'm going through what they're eating, I tell patients, cut whatever bad thing you're doing, I feel, whether it's excess soda or excess French fries, or if you chew gum or pop mints or something, cut that by 50% over the next 4 weeks. So, moderation is very important. I think your one Diet Coke a day, or your cafe latte once a day, I think that's fine. But everything's in moderation. And lastly, exercise and healthy lifestyle. I think exercise is incredibly important for the gut. I think it's oftentimes overlooked, but us gastroenterologists certainly spend a great deal of time counseling patients on exercise. And by that, we say at least 30 minutes of cardio exercise at least 4 times a week, or the equivalent of, if you have a pedometer or a Fitbit or something like that that keeps track of your steps. 10,000 steps a day is somewhat of the equivalent. Really helps with gut health. And by that I mean why? Because it really helps with gut motility. The more exercise you do, the more your gut moves, the more you have peristalsis, the less you have constipation, abdominal discomfort, bloating, and the less reflux you have. And healthy lifestyle, again, centers around portion control and moderation, sleep hygiene, making sure you get a good at least 7 to 8 hours of sleep every day, and that you're not eating late into the night. Okay, what are the complications of reflux? So what happens if, you don't eat anything your gastroenterologist or your doctor says? What happens? And essentially what you can have is irritation and inflammation of the esophagus, ulcers of the esophagus. I think you can see that here and here and here. This is a classic example of ulcerations causing narrowing of the esophagus, where the opening in your esophagus becomes narrowed. You develop trouble swallowing, where things get stuck, or it's very painful to swallow. Sometimes the acid reflux can be so bad, and if it goes untreated, you can develop bleeding. And that could be anything in the form of black stools, to blood in your stools, to vomiting blood, to vomiting black stuff, or to just being anemic, where you have just really slow blood loss and your doctors notice that your blood counts are slowly dropping. And then even more ominous than that would be what's called Barrett's esophagus, where the lining of your esophagus changes so much that it gets replaced with intestinal type cells that are not supposed to be in your food pipe, because the cells that are in your food pipe are very specific to your food pipe. But those cells just get damaged over time through reflux injury, and you develop intestinal cells, which is not good, because then over time that could lead to cancer. And if you smoke and you have reflux, that is a setup for complications. Now, by no means am I saying everyone who has a reflux is going to bleed or get cancer. I am not saying that. I'm saying pay attention to your body. If you have reflux, first change your diet, take a step back, or if you don't know what to do, then go see your primary care doctor who can definitely help you, or a gastroenterologist. I'm just saying these are the things that may happen if your symptoms go unchecked or untreated. So when do you see a physician? I don't want everyone to, leave this talk saying, and, I don't want to be scaring everybody, but certainly if you have consistent daily reflux symptoms for more than 2 weeks, if you have trouble swallowing, and what do I mean by trouble swallowing? Meaning that if you feel like a pills get stuck at the base of your neck, or chicken or beef or breads get stuck in the base of your neck, and you have to drink extra sips of water, or take a big gulp of liquids to help push it down, then that's concerning. If it's painful to swallow, it shouldn't hurt to swallow. Every now and then everyone gets a lump in their throat. But if it's actually painful to swallow, where you have a fear of swallowing now, that's concerning. If you have any weight loss, or if you have reflux symptoms despite these anti-reflux therapies, meaning that you notice that you came back from vacation and you've had severe heartburn, and you said, it's because I ate really poorly for that 7 days I was on the beach somewhere, and you take some Pepcid for 2 weeks and things don't get better, or you try some over-the-counter Prilosec and things don't get better, then that's when you need to call your physician to be seen. Okay, so we're going to switch gears here, and I talked the first half of my talk about gastroesophageal reflux, sort of the most important top half of your gut, and now I'm going to switch gears and talk about colon cancer screening. And I thought it was very important to add this to my talk, because I don't think that enough of our Muslim population gets colon cancer screening. And so who should get colon cancer screening? It's anyone above age 45 with average risk factors. And so I do want to point out age 45, because that recommendation just changed, I believe, 18 months ago, both by the US Preventative Task Force as well as the American College of Oncology. And then it was later adopted as well by the GI Society. So up until 18 months to 2 years ago, the blanket statement was, if you don't have any risk factors, meaning there's no family history of colon cancer, no family history of any gut issues, then age 50 was when you would start colon cancer screening. And for African Americans, it was always age 45. The risk of colon cancer is higher in a younger age group in the African Americans, but now it's sort of a blanket, anyone above age 45. So if you're in good health and you have a life expectancy more than 10 years until age 85, that is, you should definitely get colon cancer screening. It's never really too late to get colon cancer screening. If you think about it, and otherwise you're in good health, then you should get this, because colon cancer is completely preventable, and it would be a shame to miss this. So the gray area is people age 75 to 85, we say consult with your doctor. And for people above 85, we don't really recommend colon cancer screening, unless, I guess, everyone in your family lives to be 100, then, perhaps you would get that. But generally we stop screening around the age of 85, because around that time, our first goal is do no harm, right? We don't want to do anything invasive or anything to set someone back. And colon cancer screening is done for people who are expected to live for the next 10 years. Why? Because we're looking for polyps, which are growths inside your colon. And the whole purpose of colonoscopies is to pick up anything precancerous before it grows into anything. Okay, so who is high risk and who should get screening before they turn 45? So if you have ever had colon cancer, or you have been found to have precancerous polyps or a certain type of benign polyps before the age of 45, then you should get screening before that. If you have a family history of colon cancer, specifically a first-degree relative like your mom, your dad, or your siblings, or more than two second-degree relatives, you should get colon cancer screening. If you have Crohn's disease or colitis, you should get colon cancer screening at a younger age. And if you've ever had radiation therapy to your abdomen or pelvis, specifically if you've had lymphoma or uterine cancer or ovarian cancer at a younger age, radiation therapy can increase your risk for colon cancer. So we do recommend getting colon cancer below the age of 45. And then if you have a hereditary or genetic colon cancer syndrome. And, I want to preface all of this with, this can get very confusing, and I don't want you to leave here confused, but leave here just being empowered with the knowledge that, I just realized that I may need colon cancer screening. I need to talk to my primary care doctor at my next well visit so that we don't let this slip. And so that's honestly what I want you to take away from, just to sort of mention this, because again, I think it's always important to be your own advocate in your health and your healthcare. So how do we screen for colon cancer? So really the guidelines have 4 modalities of screening. And the reason why I go through this is, as much as we as gastroenterologists advocate for colonoscopies, because the studies and really all of us gastroenterologists know that the best test for colon cancer screening is a colonoscopy, where we directly visualize the lining of your colon and look for precancerous polyps and make it a preventative test. We know that there's a lot of stigma behind colonoscopy. We know that people don't want to do it, or their insurance doesn't approve it, or even if their insurance approves it, there's a large copay, and that can be, that may not be able to be easy for people to get this. There are stool tests, which are not as sensitive or specific, but there are stool tests that you can do. There's a virtual colonoscopy that we can do, and then there's a sigmoidoscopy, which is a halfway colonoscopy that we do. So these are the different modalities to screen for colon cancer. And I would say something is better than nothing. So if you don't want to do a colonoscopy, then at least, touch base with your primary care doctor about getting a stool test. So I wanted to briefly go over what a colonoscopy was. So this is your colon on the left. The camera goes in through your rectum, which is your bottom, goes all around your colon. You can see that here on the left. Your colon is usually about 80 to 90 meters long, depending on how tall you are. And it's a fiber optic camera. And you're asleep during the saw. So basically, it's all done with an anesthesia. You have an anesthesiologist or a registered nurse anesthetist in the room who makes sure that you're asleep, you're comfortable, your blood pressure's fine, your heart rate is fine, your oxygen levels are fine. And myself, the gastroenterologist, we put a fiber optic camera, flexible tube, the size of my pinky. It goes into your bottom, all around your colon. We look for polyps. Polyps are precancerous lesions. They're growths in your colon. They're little like mushrooms. We like to catch them when they're small, and we remove them right then and there. So this is a diagnostic and a preventative test. And the reason why we do colonoscopies every 5 to 10 years is it typically takes that little mushroom tiny polyp to grow from 0.5 centimeter to 5 to 10 centimeters into colon cancer. It takes about 5 to 10 years. So we like to catch things when they're very small before they turn into colon cancer. And remember that this is screening. Screening tests mean this is preventative, just like a mammogram is screening, just like a pap smear screening, just like when you see a dermatologist for skin cancer screening, it's screening before anything turns into cancer. We also look at your gut health. We look for any ulcers, inflammation. We look for hemorrhoids. We take a really good look. So I thought I'd give you a picture here. On the left is a little polyp. And although it may look very large on the left, I imagine that's about 7 millimeters. Okay, so this is going to be precancerous. If you miss your colonoscopy, on the right is a larger polyp, which I would say is about 5 centimeters. So the polyp on the left will take me 30 seconds to remove. The polyp on the right will take me a good at least 15 minutes, if not longer, to remove, putting you at risk for causing complications from a colonoscopy, such as bleeding or causing a tear or hole in your intestine. So this is the reason why we have people come earlier for colonoscopies before something grows in like this. And this is what we want to avoid. This is where that polyp, that little innocent polyp, now turns into this large ulcerated mass. And this is colon cancer. And this is something that we want to avoid. So you can see that for the most part, this is preventable when we do colonoscopies, when we see things on the left. And that concludes my talk here. Okay, I will now see if we have any questions.
I have a question.
Okay.
I was wondering if GERD ever hurts. Like, you know, you mentioned eating late and taking large meals. You know, I'm guilty of both. But sometimes I notice when I eat very late that in the middle of the night, my stomach hurts.
Yeah, I mean, that is one of the more common reasons for GERD. I mean, that's one of the more common symptoms is chest pain. So certainly chest pain, throat pain, discomfort. I mean, GERD can be very, very painful to the point where we have had patients go to the emergency room because they have such severe heartburn and reflux. And unfortunately, there's only a handful of things in our toolbox to treat that. And that is, like I mentioned, the proton pump inhibitors, the antacids, the Maalox.
Well, like I had a pain more in the stomach area. Is that possible from GERD?
So generally, if it's abdominal pain, then that would be more concerning for an ulcer in the stomach or inflammation or gastritis. And it is sort of the same concept of over acid production, but when it's below your diaphragm, in your stomach and your abdominal area, then it could be any number of things. It's not necessarily GERD. GERD is usually chest pain.
Okay, thank you. You know, what I noticed being a dentist is actually they don't get as many cavities, but their teeth, they melt on the back.
Yeah,
so,
that's what I hear a lot.
Yeah, so I usually tell them to go see their primary, and they usually, lots of times they're not even aware. I'm like, do you have any acid reflux? And they're like, no. But I said, you have a pretty significant melting, and I send them to PCP. I mean, it's up to them if they're going to follow up, but that's what we notice.
Oh, absolutely. I mean, I love it when our dentists are, you know, we have such excellent dentists in the DFW community that they're very good about picking up the damage from acid reflux to the enamel. Okay, I see a question here. I take Pepcid before taking any spicy food.
Hello?
And it works. Occasionally I get heartburn on an empty stomach. Eating food helps, little need Pepcid. So, you know, taking Pepcid preemptively, the antihistamine, the H2 blockers before an interrogating food, a trigger food, should be fine. I think the concept of the heartburn on an empty stomach is just basically you ate a trigger food and your stomach is producing acid to digest that food, and the food is gone and it's emptied and you still have that acid left over in your stomach. And then people feel better when they eat, and it's just because it coats your stomach and that acid that was produced is being used to digest that food. And so I think ultimately the advice is keep a food diary for the next 7 days of what you're eating and what your symptoms are. And I know it sounds rather onerous to do, but there are so many times patients come back and say, you know what, thank you, but no thanks, I don't need anything. I did a food diary and I figured out, you know, what is that one food that I eat every single day that gives me heartburn.
Hi.
Yes.
It can be cured. I have gastroreflux more than 7 years, and it can be cured or no?
can it be cured? So I didn't talk about the surgical options for reflux. There's no cure for acid reflux. I want to be very clear. Acid reflux, it's a symptom complex, and it's a disorder. The cure for this ultimately is, healthy diet, lifestyle changes. The next step is twice daily proton pump inhibitor therapy, like Protonix or Nexium. And if you take that for 3 months and you still have breakthrough symptoms, meaning despite taking that, you still have symptoms from acid reflux, then at that point we do testing to what's called pH and impedance testing, where we put a little fiber optic wire through your nose and we measure what is actually coming up, what is causing your discomfort. Is it acid? Is it just neutral stomach contents? Or is it really nothing, where you have esophageal hypersensitivity? So for a long-winded answer to your question, there's no cure. We need to figure out why you're having persistent symptoms. And if you're still having acid reflux symptoms despite maximal antacid therapy, then you may need surgery.
Is it diabetic also can be the reason? Diabetes?
Diabetes? So diabetes in itself, I don't think hyperglycemia causes acid reflux. Hyperglycemia, the high blood sugar, they cause other problems on the GI tract. Diabetes, the most common symptom from diabetes on the GI tract is 3 things. One, called gastroparesis, which is a delay in stomach empty, where patients mostly have bloating, getting full quickly, nausea, or they have symptoms of what's called diabetic diarrhea, where you have dumping syndrome every now and then. But I don't know that diabetes by itself causes a reflux. It's more of if you are heavy, or if you're eating poorly, or you're not eating enough fruits and vegetables or enough protein.
Dr. Ahmed, I think we should take some questions in the chat box. People are sending their questions and comments.
Acid production, is it different from burps? I usually have burps after eating. So yeah, belching, excessive belching can be a symptom of acid reflux. And again, that would be something where I would suggest you look into your diet about, try to find whatever is triggering your belching. And while you're doing, or after, if you can't find anything from that, then you can usually do a 4-week trial of either Pepsid, an antihistamine, or a proton pump inhibitor, and see if that helps. But yes, to answer your question, belching is related to acid reflux. Yes, I have heard, there are these complementary alternative type therapies that people swear by that helps with reflux, and aloe vera juice certainly has. I've had many patients tell me that aloe vera juice really helps.
What if I decide to stop, don't take in reflex medication? Is going to be dangerous or no?
No, it's not. So that's a great question. When do I stop therapy? That's actually a very good question. So, you have reflux and we put you on medication. Let's say, for example, pantoprazole, Protonix, we have you on it for twice a day and you're on it for 3 months, and, patients say, I'm doing great. And we said, okay. And they said, we don't want to stop yet. So you continue it for 6 months. And then 6 months later, how do we tell people to stop? We just say, you know what, you can just take it as needed. And up until a few years ago, we were very particular about, recommending patients to take it on a daily basis. And more recently, studies show that it can be certainly taken on an as needed basis. And, essentially the goal in GI disorders is to take the least amount of medicine possible to control your symptoms. Does walking help with reducing gastric reflux? Yep, absolutely. Any sort of cardiac activity can. I have severe cough and a lump in my throat after I eat. Doesn't have to be spicy food, can be anything. Coffee and tea make it worse, even if I have a drop of caffeine. I don't have heartburn though. Prilosec or Maalox isn't helping at all. So I mentioned the atypical symptoms of reflux. So the extraesophageal manifestations of reflux is that dry cough, sensation of globus, which is that lump in the throat. These are all the atypical symptoms of reflux. And for that, I would recommend a twice daily proton pump inhibitor like Prilosec or Protonix. Keep in mind these proton pump inhibitors, the Nexiums, the Prilosec, Protonix, Acifex, you have to take them 30 minutes before a meal. You know, you should not be taking them after you eat. You should be taking it on an empty stomach. You want to take it 30 minutes before a meal because when you eat, this is when your proton pumps get activated in your stomach to produce acid. And that's really the optimal time for these medicines to work so they can block these acid pumps from producing acid. But yes, these are symptoms of acid reflux.
So
how can I stop gas? So how can I stop gas? So, you know, gas and bloating, it can be from anything. So things that cause gas and bloating, not necessarily acid reflux, but things like lactose intolerance. If you take in a lot of dairy, you might want to try, you know, 2-week sabbatical from dairy products and see if that improves your gas. There is something called fructose intolerance. We've all heard about lactose intolerance, but there's something called fructose intolerance where we're finding out more and more people are very sensitive to artificial sweeteners. So anything with an OL, like mannitol, sorbitol. So if you chew gum, pop mints, drink sweet tea, juices, that can cause a lot of gas. So that would be sort of the first couple of things that I would take out. And then there's something called a FODMAP diet, and it's fermentable oligosaccharides. And you want to start a diet low in FODMAPs. And that's something that you guys can Google. Fermentable oligosaccharides are different types of foods, vegetables, for example, cauliflower, eggplant, the soft cheeses, dairy products, beans. These are all things that, thank you, Dr. Kidwai, she wrote it on their FODMAP. You want to have a diet low in FODMAP. These are all foods that can cause more bloating and more gas. Are PPIs prescription? No. So there are several on the market that are not prescription.
Yes, I have a question, please.
So I'm sorry, let me just finish that one statement. Sorry, my daughter wanted to say goodnight to me. Prilosec, omeprazole, Nexium, esomeprazole, Protonix, pantoprazole, I know are over the counter and do not require prescription. I think it's a 20 milligram dosages. I have not been to Costco in a while to look again at what's over the counter. So I'll have to, this reminds me, I usually try to go at least once a year and look over the counter what things are now available over the counter. But off the top of my head, those PPIs are not prescription. But if you want the high dose, and quite honestly, it's way more economical to get a prescription, then I would certainly suggest getting a prescription. Okay. I'm sorry.
Is there any medication or any medicine it can cause gastroreflex? Any medication like diabetes medication or any other medication it can cause gastroreflex?
So the most common medicines that cause reflux that I mentioned earlier is aspirin and NSAIDs, which are non-steroidal anti-inflammatory drugs like ibuprofen, Aleve, Advil, Motrin. Those are the most common that cause reflux. I know the medicine for osteoporosis, Fosamax, was notorious for causing irritation of the esophagus. That's something that definitely your doctors recommend to drink, you know, a tall glass of water and just sit upright for at least 30 minutes. But to answer your question, diabetes medicines generally don't cause reflux. The blood pressure medicines, the cholesterol medicines, typically they don't cause reflux.
So aspirin 81 milligram, you mean?
Yes, but I don't, if you need to take aspirin, then I definitely recommend that you take aspirin. I by no means, if you need to take aspirin, don't stop taking aspirin just because of reflux. But just know that, you know, if you have to take a baby aspirin a day, probably best to take it in the morning or at lunch, not right before bedtime. And, you know, maybe take it with a tall glass of water.
Thank you.
Yes. Sorry, I was just checking on my phone to see if there were any other questions. Yes, is there a way I can get an appointment with you? Yes, I can. Well, I don't know if I'm allowed to give my office information on here. Let me ask the AMWPA board. I don't want to violate the rules. But Dr. Kidwai can touch base with you and give you information on how to get an appointment with me.
Sure. On the flyer, you can see our address, amwpa.sec@gmail.com. You can email her and she will get you in touch. There is a question I am getting, Dr. Ahmed. It's about use of apple cider vinegar in reflux. Have you heard anything on that?
Yeah, so that's one of the sort of old wives' tales or medications that our parents tell us, or at least they did tell us to take. So yes, apple cider vinegar, contrary to what we think actually will help, like a teaspoon of apple cider vinegar certainly helps with reflux. And no one understands why, but it has been shown to be helpful, and actually helps with gut health too. It's an appetite suppressant, and it also helps with some degree of gas and bloating. So it's one of those things that is one of those complementary therapies that's actually very useful for the gut. Oh, okay. I will, yes, I will certainly share my information. I at Texas Harris Methodist, and I can write down my office number here for you guys if anyone wants to see me. I'm located in Fort Worth though, so.
So Dr. Ahmed, one last question on this apple cider vinegar again. Is there a particular time to take it, before meals, after meals, in between?
No, there's no specific time. With these sort of medicines, you don't have to time it around meals at any time now.
Okay. Yeah, it seems counterintuitive to me though. It's an
I agree.
acid like vinegar.
No, I totally agree. And I don't know how it works, but I've had a number of patients tell me that it works. And I think it mainly works for people with mild symptoms, not the patients who are already taking twice daily Protonics. So sort of the mild occasional symptoms, if you don't want to take a Tums or a Rolaids, apple cider vinegar will tend to help. It's usually just a small teaspoon.
It's
sure, go ahead.
Is there a gastroflex that can make me feel tired?
I'm sorry, I'm just putting down my office phone number here for you guys. Okay, is there a GI disorder that can make you feel tired? No, not necessarily. Acid reflux should not cause fatigue. It should not decrease your energy levels. It sounds like you mentioned maybe diabetes. I mean, diabetes is unfortunately way more likely to cause fatigue than reflux disease. Certainly, if you have some of the more serious GI disorders like Crohn's disease or ulcerative colitis, or if you're anemic, those are things that can cause fatigue. Is belching just as dangerous as acid reflux, and is it possible to have belching and not acid reflux at times? Absolutely. And so, belching, what is belching? Belching is basically where your stomach has built up with air. What caused the air in your stomach? It's really, the bacteria that live in your gut. You have to take a step back and remember that your gut, and by gut, I mean your whole GI tract, is home to billions and billions and billions of bacteria. We're talking like 10 to the 38th power bacteria. And these bacteria have to live in this perfect balance between the good and bad bacteria, symbiosis. And things that alter that imbalance are your environment, your diet, your stress levels, your genetics. And when there is that imbalance by either over acid production, under acid production, by different changes in your diet, the bacteria ferment. And when they ferment, that causes gas. And when that causes gas, you're bloated, you're belching, and you're flatulent. You're passing gas from below. So yes, you can have belching without acid production.
What about the brybiotic? Brybiotic can help for gastroflex?
Probiotic?
Yes.
No,
Yes.
yeah, probiotic is not helpful for acid reflux. No, I think a probiotic is helpful if your symptoms are mainly gas and bloating, but really for having acid reflux, I would be wasting your money if I prescribed a probiotic for you. You know, probiotics have just exploded on the market over the past 10 years. And there's really, you know, other than gas and bloating, and maybe some cases of very mild diarrhea, are probiotics helpful? I think someone just wrote here a very good reason for why apple cider vinegar. In the US, you're not allowed to label something as vinegar unless the acidity level is at least 4%. But unlike others, apple cider vinegar is the one with an alkalizing effect, that acidic ACV promotes an alkaline environment inside your body. Maybe this could be the reason apple cider vinegar helps with reflux. That sounds plausible to me.
Do we have more questions? Anyone? We started late, so
I know.
you know, we have a few more minutes. Sounds like everybody's pretty much got their answers. So maybe we'll wind up now. Okay.
I have a question. The rhubarb, there is something is called rhubarb. When I take it, it helped me like 70% to reduce my gastroflex.
Rhubarb, it's a type of vegetable or a fruit. I don't know. I mean,
yes, it's type of vegetable. Yes,
vegetable.
From whole food.
Yeah, I've heard of rhubarb, but to be honest, I don't know if it's something that helps you. I mean, I imagine it's not going to hurt anything. It's not high in sugar content, and you know, if it's a vegetable, and if you're having some benefit from it, then I think that should be fine. Yes, this is recorded, and yes, the recording will be available on YouTube channel. And there was a question, can PPIs be taken long term? So this has been a hot topic over the years. PPIs have really been the mainstay of therapy for gastroesophageal reflux disease, and there has been quite a bit of buzz about the potential side effects of PPI therapy. And namely, you know, I mentioned that this does have to be monitored. So your kidney function has to be monitored while you're on proton pump inhibitors. Really just a blood test. I usually recommend it twice a year, every 6 months. There is a risk of bone loss with proton pump inhibitors. How significant that bone loss is, it's not significant, but you know, generally speaking, you should get a bone density scan after, you know, at least 5 years of PPI therapy. And then over time, there were some reports that perhaps PPIs may cause dementia or may increase your risk of pneumonia, and that's really been largely debunked. I think there was a meta-analysis that came out sometime last year that really showed that, you know, it's not really known to be a cause and effect relationship with dementia and a lot of these things. But we do recommend, for the most part, that people who are on PPI therapy long-term to get kidney function testing done twice a year and a bone density scan periodically.
What about warm milk? When I drink warm milk, sometimes it helps me also.
So generally, milk will, in the long run, worsen reflux, but if you're deriving benefit from it, that's fine. It's probably, you're probably not drinking whole milk. I imagine you're drinking like 1% or 2%. So I imagine the fat content is probably not that much if it's helping your reflux symptoms. Besides PPI, what other therapies are there? So I did mention the topical therapies, the acid binders such as Maalox, Tums, Rolaids, and then I talked about the antihistamines such as Pepcid and Tagamet. Those are really the other therapies besides PPIs. There's also something called Carafate, Sucralfate, which helps coat the esophagus. That's prescription strength only. That's also been shown to help with reflux.
Okay, so I guess that we can wind up now. Dr. Tasneem, thank you so much for this tremendous talk. People have benefited greatly from it. This is a very popular topic. You have done this before, and inshallah, we'll keep bringing you more and more topics on this. Someone asked in the chat if this talk is recorded. Yes, this talk is recorded. It will become available on YouTube. Our channel is amwpa.org. So when you go into YouTube, look for amwpa.org. And there are, all our lectures are available on that. So you can subscribe, like, and share. Before we finish, I want to thank our secretary, Natasha Durrani, who's in the background doing all the great work, and she never gets a credit. Thank you, Natasha. And thank you everyone for coming. Thank you for attending.
You are very welcome. Thank you.
Okay, assalamu alaikum, everyone.